All right, good afternoon, everybody. Welcome to Pulmonary Critical Care and Sleep Grand Rounds for Yale School of Medicine. I'm Kathleen Atkin, one of the associate professors with our division. Want to welcome our virtual applicants and hope you're getting a good flavor for what we can offer for your teaching and career development here. I am thrilled to be able to invite Ian Campbell Murphy to the podium to present his grand rounds. This is work that kind of came very organically from Ian, who came to us from WashU for a residency, where he really set the tone for his career as someone who is passionate about patient care and thinking about what patients are experiencing and what we can do to make things better. So any of us that's worked with him knows what a delight he can be to work with. He's always extremely helpful and happy, and also, though, thinking about what he can do better. One of the first times I met him was when he was at the VA consult service with me, and we were going to see somebody with COPD, and he's counseling them about phantom limb pain. So that just sort of tells you how well-rounded an individual Ian is. So I can't say enough about the hard work he's put into his project with me, and want to turn it over to Ian for his grand rounds. Welcome.
Thank you so much, Dr. Atkin. Go with that? All right. So hey, everybody. Thanks for being here. Welcome to all the applicants on Zoom. If I am the one thing standing between you and finishing the day, I apologize. I promise I'm going to make it interesting, and I hope you've had a great day so far. So let's talk about sedation, stewardship, rise of the machines. So I'll give you an idea of where we're headed today. We'll review our sedation guidelines. We'll talk about evaluating sedation practices during COVID. We'll talk about some local and national sedation stewardship interventions. And then we'll get to the future and AI-controlled sedation. So I'm going to introduce you to a patient. This is a 70-year-old man who came to us with COVID. It's a history of COPD, hypertension, type 2 diabetes, and he presented with shortness of breath. Unfortunately, it worsened, and he was intubated for respiratory failure. And you, as a thoughtful provider, ask the family if there's anything you can do maybe to make his stay more comfortable in the ICU. And the family says, you know, actually, he loved Frankie Valli. If you could play that music, it would really be helpful. And so, you know, here are the Jersey Boys. So this is Frankie Valli and the Jersey Boys. I do recommend this show if you haven't seen it. It's really fantastic. But, you know, despite your best efforts, unfortunately, there's still a lot of concerns for vent dysynchrony. And I intentionally use dysynchrony here and not fighting the vents. Important for us to avoid using those adversarial terms when we're thinking about patients. But this is a patient who's certainly uncomfortable on the ventilator. And a question is raised, right, whether or not this patient is getting adequate sedation. So let's take a look at what the sedation actually looked like. So here's day one. You can see he's on fentanyl and propofol, fairly low dose. 2 days later, it's increasing. He's now on 1.5 and 40. And there's still indications that this patient is agitated, right? In nursing notes and resident notes still says potentially agitated. 2 days later, it's still increasing. So on higher doses of fentanyl and propofol, you review the chart and you see, you know, he has now the bowel movement since admission, and the tube feed seem to be intermittently held because of concerns for aspiration. And still sedation is increasing. We've now added on Precedex. We've added Seroquel ostensibly for agitation. And 2 days later, it goes even further. So now we're nearing the maximum dose of things like fentanyl, propofol, and he's on maximum Precedex. Seroquel's doubled. And it's right around this time the nurse calls you and says, you know, hey, his pressure requirement's jumping up, and I just sent some labs. You just may want to take a look. And so at this point, you see that there's a rising lactate, and now this patient has an increasing pressure requirement. So in your workup, you decide to get a chest X-ray because he hasn't had one in a few days. This is the image that you get back. Yeah. The gas, right, there, because there's clearly some free air on this image, and we confirm that on CT. And we approach surgery and say, this is a patient we're worried has a perforation. And the surgical team says, unfortunately, this is a non-surgical candidate. So then you return to family and you say, unfortunately, you know, he's got a rising pressure requirement, his lactate is increasing, and we don't have an answer. We don't have a solution with surgery. And the family says, you know, we'd really like him to be comfortable. And this is an extreme example, right? This is something that we rarely see. but I think all of us can have in our minds examples of patients that got a little extra sedation that led to one extra day on the ventilator, an increased chance of delirium. And I think it's important for us to ask, how do we prevent this from happening? And so there's some wonderful guidelines developed by the Society of Critical Care Medicine, the PADIS guidelines. I know all the fellows in the room very excited about the pain, agitation, delirium, immobility, and sleep disruption guidelines. And they're helpfully broken down by letter, and I want to review them really quickly. So A is assessing and managing pain, making sure we're thinking about a CPOT score, choosing appropriate analgesia. B is both spontaneous awakening and breathing trials. Again, remembering that we're all facile with doing breathing trials, but remembering we should pause sedation and do that awakening trial when possible. C, of course, is choice of sedation. Are we choosing a drug that's appropriate for the patient's age, their renal and liver function? Is there something that we can choose that's going to decrease their rate of D, delirium, right? We're thinking about we're using a CAM-ICU score, trying to reduce things that are going to increase rates of delirium. A lot of what I'm going to talk about today is on the assessment and optimization of these factors, but I think it's really important also to emphasize E, which is early mobilization, and F, of course, family engagement. So when we talk about sedation, right, we can't get away from sedation without talking about Richmond agitation scoring as well. And I put this up here not because I want to talk through every element, but just to highlight and remind ourselves that verbal stimulation is required if we're giving someone a RASS of -3 or -2, right? Lots of times we go see a patient, we yell at them, they don't wake up, we have to shake them to wake up, RASS -1. But realistically, right, that might not be where their RASS score actually is. And so when we're thinking about the drugs we're delivering and the sedation we're giving, it's important to think about that this is an optimal sedation score. And so -4 and -5 are physical stimulation. And so why are the guidelines important, right? These are set out. We talk about them every time we're in the unit. And so this is a really nice study that was done. This is Wes Ely's group. This is 15,000 ICU patients. And what they looked for was sort of a dose-responsive relationship between the elements of the bundle being performed on the x-axis and outcomes. So if we look at just ICU length of stay, we can see that as we're getting higher and closer to 100% compliance, there's a shorter ICU length of stay. And this is replicated with total hospital length of stay too. And as you might imagine, it improves mortality, right? So again, it's almost a dose-responsive relationship. As we're following more elements of the guidelines, we actually see improved mortality. So the next question, I think really obvious here, what can board games teach us about medicine? So this is Pandemic. This is a board game that was invented actually before COVID, I think gained some popularity during that time. Pandemic is a cooperative game. It's great, it's really fun. And if you were gonna play Pandemic, it would come with a rule book or a guidebook. And generally, it's probably a good idea to follow those rules. But if you play a game enough, you decide, you know, there's a little tweak that we use at my house. There's something that's a little different, we think is more fun, and it just makes gameplay a little different. So sometimes there's room for a house rule. Here are some house rules that you might be playing with you didn't already consider. So this is Monopoly, right? So free parking, a famous house rule. And it's that if you land on free parking, you get all the money in the center of the board. Now, the actual rule is that free parking is just a free space. Nothing happens. The other one is that if you choose not to buy a property in Monopoly, nothing happens. The actual rule is that if you choose not to buy a property, it goes up for auction. Everyone else at the table can bid on that property. And so these are probably, you know, these house rules make the game more fun. We probably play with them. But what happens if a house rule breaks the game? So this is Settlers of Catan. All you need to know is that you need to connect settlements and roads to try to collect victory points. So if you made a rule that was roads don't need to connect to settlements, gameplay won't work right. If I made a rule that anytime 7 is rolled, I get all the resources, people might be upset and say, well, that's not really equitable. And if I made a rule that if you roll snake eyes, you have to trade stethoscopes with the person on your right, you know, people would say that's just ridiculous and waste resources. And these are rules, of course, we think about board games, but maybe there are things in medicine that we do. Maybe there are house rules that we use every day that fit into some of these categories. And so what happens if you follow broken rules or your house rules don't work well? Well, in board games, you end up with this, right? So this is flipping the board of Monopoly. And right, if we think about ways to evaluate whether there are broken rules or not, right, how should we evaluate the house rules that we made during COVID? So we think back to our patients. Did we develop different rules for patients during COVID? And there are lots of factors that potentially led to this poor outcome, right? Was it the disease? Was it our sedation? Was it something environmental? There are lots of things probably that affected his care. And there have been some really nice retrospective studies that have been done to try to answer this question of what happened during COVID. So this is a small study from MassGen, and they looked at 90 patients, and they asked this simple question, which was, what's the percentage of intubated patients with COVID who got drug doses that were higher than the recommended range? And you can see the 6 drugs that they looked at and their max doses, which are fairly close to ours, a little bit lower. So even 3 days in, I'm going to highlight just propofol and hydromorphone. You can see in the propofol group, so at day 3, 27% of patients, intubated COVID patients, are getting doses of propofol that are higher than the recommended range. Similarly with hydromorphone, where 17% are getting doses higher than the recommended range. And they looked out to 10 days, and you can still see that this trend continues at the bottom of the graph, where almost a quarter of the patients in each drug group are getting doses higher than the recommended range. So basically demonstrated, right, a high percentage of patients got doses outside the recommended range. And now the question becomes, okay, so we know that they got higher doses. How much drug did they get? And this is a really nice study, and I'll tell you exactly how long the time frame was in a second. But they looked at non-COVID intubated patients versus COVID intubated patients in the exact same time frame, and they asked, how much drug did they get? So looking at fentanyl, you can see that non-COVID intubated patients with ARDS got 1,500 micrograms, and in the same time period, the COVID patients got more than 5,000 micrograms of fentanyl. The trend continues with propofol, where we can see that there's almost a doubling with COVID. And midazolam, pretty stark difference here, where you can see non-COVID patients getting 4 milligrams and COVID patients getting almost 32 milligrams of midazolam. So what time frame do we think this is, right? Looking at these doses, is this the whole ICU stay? It's a couple of days, weeks? Answer in your own head. So it's 48 hours, which I think is pretty sobering and staggering in terms of considering that these patients were probably intubated and continued on these same doses for a long period of time. And this same study asked, well, we know that they're receiving a lot of drug, so how does that affect mortality? And this is, again, it's a 2-center study, WashU in Iowa, and they looked at peak COVID times, about 400 patients enrolled, and they asked, is there a difference in mortality with early light and early deep sedation? And so just breaking it down on RAS helpfully, so you can see that patients who got early deep sedation, meaning the sedation within the first 48 hours was at a RAS of -3 or lower, had worse outcomes compared to the patients who got light sedation initially. And right, in thinking about maybe there are other factors at play here, it's a good question, and the answer is maybe, because there was a slight difference in SOFA score, and as we know, SOFA score is sort of a objective measure of how sick we think a patient is, with a higher score meaning that they are sicker on arrival. And so maybe this is a reason for this difference. But even so, I think it's important for us to consider the fact that sedation seems to be an independent risk factor for these patients and probably plays a role in poor outcomes. And so now we have data showing that maybe there are house rules made that we're giving extra sedation and it's outside the recommended ranges. And the question then becomes, are there other things that are impacting care? So I'm going to talk about therapeutic creep. And I'll give you an example of what this looks like. So here are 2 patients next door to each other, one with COVID, one with Pseudomonas. Here are their initial vent and sedation. So COVID patient, 70% FiO2, PIPA 10, sort of moderate sedation. Pseudomonas patient, definitely decreased ventilator requirements and decreased needs in terms of sedation. 2 days later, COVID patient has gotten significantly sicker, right? So their oxygen requirement has jumped. They're now paralyzed with cystatricurium. And as you might imagine, their sedation has also increased proportionally. Now, what's interesting, what happens is that the Pseudomonas patient has increased their FiO2 a little bit, but their sedation has jumped markedly. And again, this is sort of an apocryphal example, but I think the objective is to highlight the fact that did we just get really used to seeing patients on super high doses of drug, right? Did we just see so many patients that were just on propofol of 80 that the heuristic, the house rule in our own minds just changed, that we just got comfortable giving these doses of drug without asking whether or not we should change our practices? And there are lots of reasons why excess sedation occurs, right? Environmental factors, things like it's a high stress environment. We have to don and doff PPE constantly. There's people in the ICU who are not comfortable dealing with critically ill patients, particularly during COVID surges, drug shortages that presented a huge issue. And then the more institutional factors, right? Did we develop these house rules? And did we take off the guardrails, right? Did we stop nudging ourselves to make good choices about sedation? And then finally, provider patient factors, right? Is there therapeutic creep that's impacting our care? Or is it just that this is a heterogeneous, really complex disease process that's unique in each patient? And so if we're thinking about how to sort of help ourselves with realignment, how to manage excess sedation, we want to think about how do we decide on the best house rules? And again, I'm sure you're excited to learn that board games give us an answer. So this is the Spiel des Jahres. This is the board game of the year. Some notable winners: Settlers of Catan, Ticket to Ride, Pandemic, Codenames, which is a wonderful game. I do recommend it. You can play it on Zoom. And I know everyone was following along, but spoilers, the winner this year was, of course, Dorfromantik, which interestingly is the very first video game to ever win. And so this is Dorfromantik, where you build a universe in a virtual world using tiles, and you have to follow certain rules, like your river has to be this long, your forest is this big. And it was a wonderful game that is obviously caused a stir, but created maybe some insight into thinking outside the box. So I want to give you some examples of winning ideas that we've had at Yale. So I want to highlight the ICU Sedation Optimization Committee, headed by Dr. Haneden, with respiratory therapists, pharmacists, nurses, lots of clinical staff. And one of the goals that they set out was to reduce midazolam usage from 2021 to 2022. And they did this in a couple of ways. And one is to introduce the sedation signature care pathway. This is a snapshot of what that looks like. So if you go into Epic and you click pathways and you go to sedation, you'll see a huge table, but this is just part of it. And I want to highlight a couple of things. So one is that it allows you this nice split between light and deep sedation. And it kind of nudges you down here. It says, hey, have you thought about delirium? Do you want to activate that pathway? Do you want to call PT and OT? Are these the D and E elements of making sure that we're, managing appropriate sedation? And then on the other side, it's prompting you again, choose propofol if you can. And then if a patient is intolerant, maybe pick lorazepam, right? Nudging you away from choosing the drug that we know maybe has worse outcomes. So how did it work? So as you can see, prior to the intervention, we have fairly equal numbers of midazolam exposure between two patient groups. After the pathway goes in, significant reduction in the amount of midazolam that patients are receiving. So there's a 47% decrease. And how did that affect patients? How did that affect outcomes? So you can see on the right side of the red sedation intervention that the post-intervention patients had a lot of benefit. They had decreased time on the vent, they had a shorter ICU stay, an overall decreased length of hospital stay. And then back to our friend, the SOFA score at the bottom. So interestingly, the post-intervention patients have a slightly higher SOFA score. So were these sicker patients that had still significant benefit just from the introduction of this pathway? And what's great is that even beyond the patient benefit, they also saw that they saved the hospital about $2 million per year just based on decreasing ICU and hospital length of stay. And I'm sure you're thinking, okay, so we didn't give midazolam, but did we just crank up propofol on all these people? Did we just, give them tons of extra drug? Nope. So no increase in concomitant medication use during this time. And so I think, it's only appropriate that we give this team the Spiel de Yale, right? Which is, and so, you think about the success of a local project like this and knowing that there was excess sedation during COVID, Dr. Atkin and myself started thinking about, can we build a big project that can impact care on a larger scale and maybe provide some national guidelines? And so where we ended up was exploring the national VA sedation practice during COVID. And we wanted to create clinically meaningful change. We wanted a project that would really impact patient care. And so we identified our stakeholders, patients, pharmacists, the VA team at large, thought about how we can assess things, right? We want to make sure that we're quantifying and identifying actionable things. Then we're helping people realign with guidelines, right? Making sure we're maybe putting those guardrails back up, making sure people buy into what we're selling, with an ultimate goal of getting to sedation stewardship. And the way we chose our tool was we wanted to think of something that had sort of an ease of data collection, that we could collaborate with pharmacists. And then, of course, more than anything else, we had real world clinical data. And we ended up with a medication use evaluation. And that's a systematic approach to developing to assessing the safety, appropriateness, and effectiveness of medication use with an overall goal to improve patient care. To give an example of what this looks like, so if you're going to evaluate antibiotic prescribing for urinary tract infections, you would ask in real time, what are we doing when we're prescribing drugs for UTIs? So is there a UTI confirmed? Are we using PO drugs that are appropriate spectrum? Are we narrowing when we can? If they're on an IV drug, are we narrowing? Is their length of treatment appropriate? And then you can take that data, because it's real-time prescribing practice, and then when you add interventions or add safeguards, you know that it's going to impact change because you know what the real-time prescribing practice is. And so I just want to give a shout out to the VA MedSafe team that has done an incredible job supporting us through this process. They've been just wonderful in working with, and our goal was to look at their model for antibiotic stewardship and apply it to sedation. And just say, how can we practice sedation stewardship? So here's what our project looked like. We had 13 sites that participated, and we looked at 3 time periods when asking about sedation. So we had a pre-COVID time period where each site almost served as its own control. And then we had COVID year 1 and then COVID year 2. And we went through this really wonderful iterative tool creation where we worked with pharmacists from all of these sites, and we tried to design the best sort of chart review tool possible. And that led us to, how do we identify our variables? How do we operationalize them? Right? How do we pick the best way to grade sedation, or how do we grade RAS? And then outcomes. So we added things that you might imagine for outcomes, right? Mortality, length of stay, delirium, ileus, but also things like antipsychotic prescription. Are there patients that are getting antipsychotics that are continued when they go to the floor or continued when they go home? Are we ordering a lot of CT heads on people who are over sedated, right? And what's the cost of a CT head, aside from a radiologist, is, taking a nurse and a respiratory therapist off the floor. And then finally, were these patients so deeply sedated that they actually needed a reversal agent? And so we ended up doing our chart reviews between April and June of this year. And here's how things broke down. So we had 870 charts reviewed, fairly high exclusion. A lot of that is because we capped our patients at 14 days on the ventilator. Some of that is because in our initial pilot data, it took up to an hour and a half to review one patient chart. And so to spare a lot of our reviewers and myself, we decided to cut that down a little bit. And then the other thing is that, at 14 days, we're really talking about and thinking about tracheostomy. And we know that sort of the sedation requirements and needs of a tracheostomy patient tend to change, and they're on the ventilator for a long period of time. So for that reason, we excluded them. We ended up with about 150 patients per group. And while we're still doing data analysis right now, happy to share some of our initial findings. So here are our demographics. This is the overall cohort. And so most of these patients are male, in their 70s. They have a Charleston comorbidity index of 4. The Charleston comorbidity index is basically exactly what it sounds like. The higher the score, the more comorbidities you have. About 18% had COVID, 16% had at least a chart diagnosis of ARDS, and then 60% were transferred out to the step-down or medical floor, and our overall mortality was about 33%. So now I just want to share kind of what our initial data look like, so some of our prelim data. So here's our RAS scoring, and it's a little bit confusing, but essentially what we're asking here is what's the percentage of patients who are hitting each of these RAS ranges in a given day. And so I just want to highlight here, let's just look at goal. So for patients who are hitting a goal RAS score in the pre-COVID timeframe, about 80% are hitting it. As you might expect in year 1, that decreases significantly. So now we have only 66% of patients hitting that goal RAS. And what's great is that we seem to have returned to pre-COVID levels, right? Where now about 79% of patients are still hitting that RAS score. And what about drugs? And so we did look at drugs longitudinally. We looked at the entire length of stay. Right now, I'm only able to present just the first 48 hours, but I think in linking it to the study I presented before, it's sort of nice to see the similarities. And so if we just focus on fentanyl, you can see again, drug exposure in the pre-COVID time, about 1,200 micrograms, jumps up in year 1, and then interestingly continues to go up in year 2. Right, so why is that happening? Is this a therapeutic creep phenomenon? Will this data will it change as we maybe draw out to beyond 2 days? It's just fascinating to see that difference occur. Propofol, again, similarly, you can see sort of the max rate being similar from pre-COVID to year 1 and then jumping up in year 2. And then finally, midazolam, where we can see there's the jump we expect to year 1. And then slowly, it seems like maybe we're getting back to that pre-COVID level. Mortality follows a similar trend where, again, mortality increased significantly in that first year of COVID, and then hopefully is now getting back to the pre-COVID levels, but it seems like it's still maintained at about 36%. And so thinking about this data, as we're analyzing it, as we're thinking about ways that we can improve sedation stewardship, the question becomes, is there another adjunct we can use? Is there something else that can help us? And that is, of course, the future, right? An AI-controlled sedation. Right? And always remember, right, if Dorfromantica can win a board game contest as a video game, we just need to be thinking broadly about the way we approach things. So if we think about AI, there's tons of questions we want to ask. 3 of the big ones I wanted to ask were, can AI dose medications? Who does a better job? And then can we really trust a device to deliver medication safely? I want to give you an example of how this is already in practice and fairly commonly used, an example that's really important to me. So this is a continuous glucose monitor and insulin device setup. Particularly important to me because my wife is a type 1 diabetic and also a pediatric endocrinologist. And so she wears these and prescribes these. And them working allows me to have an incredible wife and the best board game partner in the world. So the way that this works is the continuous glucose monitor continuously samples interstitial fluid and measures glucose and says, hey, glucose is rising, glucose is falling, sends a signal to the insulin pump, which then makes a decision about whether it's going to change a basal rate, whether it's going to change the way that it gives dose corrections for carbs. And my wife can still, add her own carb count. She can change all the basals herself. But in and of itself, this system can talk with itself, make changes without any additional intervention. And so what we think about that as a closed loop kind of system. And as we go deeper into AI, I just want to give you a couple of flavors of artificial intelligence. So when we're thinking about AI, right, do we want a chess grandmaster at something that knows how to win a game just by moving pieces? Or do we want something abstract, something that's a little bit scary, right, like ChatGPT? So I want to talk about a couple of different machine learning modalities and how they're already being used in medicine. The first one is supervised machine learning. And so machine learning in a supervised fashion is where you teach an AI model an association. And you teach it, okay, this is an apple, this is an orange, this is a banana. You give it a whole assortment of fruit, and then it groups them for you. It says, these are all apples, these are all bananas, these are all oranges. The way that we're using this already is with nodule identification. So you teach an AI program, this is a normal CT, this is the mediastinum, this is parenchyma, this is the blood vessel. Then you teach it, this is a nodule. You give it a huge subset of CTs, it goes through, picks them all out for you. Unsupervised learning is sort of the opposite, where you give the AI model a huge amount of data and you ask it, find me the pattern. The way that we're using this is in IPF. And so you look at a whole subset of IPF patients and you ask, based on their CT scanning, is there potentially a difference in mortality? Is the honeycombing pattern that's basilar or peripheral, does that affect the way that they interact with drug or their clinical course? And so both of these examples are fairly linear. It's sort of I teach you something and you feed it back to me. But if we're thinking about something as nuanced as sedation, I think it's important to consider that we want something more abstract. And so that's where I'd want to talk about reinforcement learning. Easy way to think about this is a self-driving car. And so if you tell, a self-driving car starts at point A, it has to get to point B, it has to learn how it's going to do that. It has to learn what speed, what to avoid, what turns to make, and it can over time create this optimal route. And if we think about sedation as a potential optimal route that we want to create, this seems like a great model. So what would that look like? So this is a simplified model of what AI learning could look like for sedation. And if we look at the patient in the bottom left-hand corner, have our little AI friend. And so maybe we start just measuring a BIS score to get an idea of sedation, and then a map to make sure that this patient is not over-sedated. Then we'd want to identify the state, which is the current sedation level, and the reward, which is the goal sedation level we want to get to. And the machine makes a decision based on what's called an optimal Q table, which we built beforehand, which says this is where I want things to end up. So make decisions to get me to this endpoint, which is essentially an optimal Q table, which is saying I want the RAS to be this, I want the map to be this, make decisions that get us there. And so you could see how this circuit would just continue over time until we get patients to that optimal outcome. And this is very simplified, right? There's a lot of nuance to sedation. We probably want a lot more inputs and factors, but people are already starting to ask the question, who does a better job, right? So this is a study that was done where they taught an AI model to dose propofol and fentanyl on simulated patients, and they asked them to achieve a Riker score of 4. So Riker, like the RAS score, again, a higher number meaning more awake, a lower number meaning more sedated, and they asked clinicians to compare themselves to an AI policy. And when they looked at clinician policies, so this is, they put a box for every hour that a patient spent at a Riker score while they were trying to get to goal. So this is at least 1 hour, the Riker score, not at goal, for patients under clinician policy. And so you can see, right, what we're doing is we're maybe over-sedating a little bit, and then maybe we're fine-tuning as we're maybe under-sedating, but eventually we get to goal. How does AI do? Just one dot, right? It learns really, really effectively how to dose propofol and fentanyl, again, simulated patients, but if you teach it something, it can easily dose sedation and have significantly less fluctuation. And because there's less fluctuation, there's also less drug delivery. So clinicians use about twice as much drug as the AI model. Again, simulated patients, seems like it's sort of otherworldly, but I will give you an example of a functional AI sedation model. So I want to introduce you to McSleepy. So this is serious. Named I'm pretty sure during Grey's Anatomy hype. This is not McSleepy. No, this is IBM's Watson. This is McSleepy. So McSleepy was developed in McGill in Canada, and McSleepy is a closed-loop anesthesia delivery system, and it does things like measure EEG, BIS, it measures heart rate and MAP, and it makes decisions about delivering drug. And so you can see this is a surgery at McGill where they're using the Da Vinci, so quite a technology-heavy surgery. And they asked the question for patients who are getting cardio bypass surgery, so fairly complex sedation needs, can this AI model effectively deliver drug? And they saw that about 80% of patients who underwent the surgery got appropriate drug delivery. And in fact, the 20% that sort of failed drug delivery, it was really more to technology errors, right? The AI model didn't give 100 mics of propofol, without thinking about it. It was actually more that there were communication errors. So AI potentially has a potential to help us actually deliver sedation. And what about helping us with oversedation, right? What about helping us with the consequences of oversedation? So there have already been studies that have shown that AI can detect sedation level via EEG, so maybe give us the best idea of what a RAS score actually is. It can assess CPOT scores with facial recognition software. And AI can even identify patients at risk for delirium. And so as we're thinking about, all the benefits of AI, I just want to take a second, right, to talk about pitfalls, because there are lots of them. Right? AI is inherently created by us for now. And what you put in is essentially what you get out. And there's a lot of areas potential for bias if we are creating the AI, right? Thinking about the way that it learns facial recognition. What is the group it learns on? Is that different from the group that it's trying to give you data on? Are people going to have access to AI? Are there going to be significant socioeconomic differences or barriers to care? We thought about data privacy and someone breaking into the AI or stealing data, whether we can use it safely, whether we can use it ethically. And then, of course, employment concerns. And by that, I mean our employment, specifically, is AI coming to take all of our jobs. So let me give you an idea of what it could look like if you integrated AI into a hospital room. So this is an example of a delirium prevention schema within the ICU. And if you look at it, it really doesn't look dissimilar to what is existing in our rooms now. So you have, the classic physiologic markers, but it also has a camera for facial recognition, right? Looking at grimacing and pain scores. They added accelerometers to try to see if limbs are moving at a certain period of time. And then it's measuring like light intensity and decibels and sound in the room. And so you could imagine how an AI model could integrate all of this data and give us information that said, hey, this patient is at risk for deteriorating even before their blood pressure would have dropped 1 point. Or this patient is at risk for delirium before we'd known that something was going to change. And the next step would be, can the AI model integrate that data, look at it, and then make a decision? Can it give a drug before a patient deteriorates? Can it do something in the room to try to improve circadian rhythm? And if it's doing that, and we're allowing it to make clinical decisions on its own, I know we're all worried. This is the rise of the machines, right? This is Skynet is active, AI is taking over. But I think AI is here to help, right? AI is willing to sacrifice itself if needed, but it's an adjunct and a supportive tool. So I'll leave you with some final thoughts. Oversedation can really be harmful. And, we think about COVID patients that they certainly receive doses of medication outside of guideline-directed therapy. Some of the local sedation pathway implementation has been really successful, both on the patient and hospital level. Our national study sort of replicated those findings and really argues for making sure we're aligning with our guidelines and recommitting to them. And finally, AI has a vast opportunity to help us in the ICU, both optimizing sedation and reducing patient harms. So one final thing, it's okay to make house rules, right? Just make sure they don't break the game. So some references, a huge thank you to Dr. Atkin, the entire VA research team, Dr. Mathey, Dr. Kaminsky, Dr. Hanavan, Dr. Pisani, who saw some early drafts, the huge family here, thank you for being here, and of course, my amazing wife. And so these are some of our favorite games. Happy to answer questions about these or anything else. So thanks so much.
All right. Thanks so much, Ian, for that stimulating talk and really provocative points to bring up. We'll open it up for questions.
Dr. Siegel, you have a question?
No. Actually, I had two, but I'll start with one. So I really loved your opening. It's a sad story, but it's really a telling story. And I think the point is, if I understood it correctly, is that the patient had a reason to be agitated, and that reason was not going to be answered by giving more medicine. And I think that one thing that I've been worried about just in our whole field of critical care is that we beg the question, you intubate a patient and you get asked two questions: what settings on the ventilator, and what do you want to start, right, for a drip? And I think that what's missing from this is that patients are agitated for a reason. And while you're getting at it a little bit by doing the pain assessment and and delirium assessment, et cetera, we don't really hear about things like ventilator desynchrony. Maybe you'll calm them down if you put them on a different mode. There are sometimes patients who, as you said, might be constipated, right? And maybe what they really need is some Miralax. I had a patient once, actually Shoka and I published this, who was going crazy because her toe was itching.
Yeah,
right. And so I wonder how you would fit this in to your algorithm, because it seems to me there needs to be a pause and ask why they're agitated before we assume that it's the right dose of medication. That's the question.
Yeah, I think that's a really good question and a really good thought. I think, like you said, it's almost like a if we're in a code and it's, reviewing the H's and T's, when we're asking the question after a patient is intubated, the question becomes what ventilator settings, what sedation, and why are they agitated, or why is this happening? Just even a simple, moment to pause, I think might be an early start to be effective. I think it's a great point.
All right, we have one of our fellows with a question over here. Here you go, Jen.
So I was just wondering, it didn't comment on the rate of correction for paralyzing and proning during sedation, because that does substantially change, but it's also appropriate. And I was just wondering if that played into some of the raising of sedation maxing.
Yeah, I think it's a good question. Do I need to repeat them, or can I hear them on the? Okay, yeah. Okay, all right, so we're good. Okay, all right. So yeah, it's a really great question by Jen. I think it's certainly true, right, that patients who need paralysis or proning are going to be on higher levels of sedation by virtue of needing those things. I think the argument that's made is that, we're still patients who, let's say, had ARDS and were non-COVID patients who were still getting sedated, were getting higher doses than the COVID patients, even considering the fact that COVID patients needed to be paralyzed. Oh, yeah. Yeah. Oh, sorry. Yeah. So the question was going back to the Mass General study where they looked at doses exceeding the recommended range. Did they take into account paralysis or proning in those patients? And the answer is no. So it was just sort of a quick 90 patient scope. I think if I drilled down, there was certainly a percentage that was paralyzed and prone, and I cannot remember what it was, but I didn't stratify by it.
All right, we have another one of our fellows here ready to ask a question. And then
great talking, and thank you. I was curious if either the MGH study or Shoka's work looked at if there's any difference between the age group, like the ages of the during COVID and later COVID, post-COVID cohorts. I guess in my personal anecdotal experience and kind of general anecdotal experience that we have this idea that younger, healthier patients often require, or we think that they require, more sedation. And I was curious if that's borne out in the data at all.
Yeah, I think it's an excellent question. And I haven't seen anything where they're really stratifying by age, and it may be because of the cohort sizes, right? That there might be fewer patients in that group. But it's an excellent question, and one that, gets at sort of therapeutic creep and heuristics about, like you said, are we just younger patients need more drug, right? It's important to consider that maybe they don't.
I bet we could ask Dr. Hanadin about that too. She had a fair amount more data than we presented here. So good question.
Where are we with AI now? I see these papers in Nature. That's very impressive. Are we ready? Is it prime time?
That's a great,
particularly in the ICU. Where do you see this going?
Yeah, I think that AI already has a lot of integration in, sort of imaging modalities that are helpful for us. And I think I think it's reasonable to assume that within, 5 years, I think we'll have AI that's helping us with decision-making in the unit. I think that we'll have some sort of tool sitting in the background that's integrating a lot of data and maybe giving us nudges as to, hey, like we have the pathways already that are sort of, these criteria, alert a sepsis panel, and maybe you should consider ordering a sepsis panel. I think we're going to get even beyond that to a little bit more granular and really patient-specific recommendations. And I'd guess within the next couple of years, it'll be, I think Epic would love this to be integrated into their system. Yeah.
All right, Dr. Siegel.
So I'm not really against AI, but I have the thought about the reason for it here is that I think that there's a problem with sedation that we see in a lot of medicine, which is, so you gave insulin as an example, where I think that patients and doctors have a real incentive to get the Goldilocks dose, right? You don't want to be hyperglycemic, you don't want to be hypoglycemic. And so everybody kind of wants the right thing. But there's so many examples in medicine where we give too much and don't deprescribe and don't come off. So for example, everybody has more oxygen than they need. Everybody's on the highest dose of inhaled corticosteroid, even though their asthma is well controlled. And I think the same thing, if you look at the doses of sedatives in the ICU, every time somebody does like shifts around in bed, the propofol dose goes up, but it never comes down. And so not only that, but we're not, you're right, we're misreading the RASs, right? Like, so the RAS isn't really -1, it's -4. So I wonder if the real lesion here is not that this is too complicated, but that for some reason we're not doing daily awakenings and we're not trying to go down on the sedatives and seeing how little we can give.
Yeah, I think it's a really good point. I think that probably, I think there are some studies that look at it, but I'd have to imagine that the spontaneous awakening trial is one of the things that is infrequently done in the ICU, and it's so important. We asked that question within our data set, and I don't think we have the analysis yet, but we asked the question, was there a spontaneous awakening trial done on this day, yes or no? And then we also asked, if not, was there a dose reduction in drug? Just trying to see, even if they didn't document a spontaneous awakening trial, did they at least consider dropping the drug? And I think hopefully, seeing the prescribing practices, we can try to create some recommendations and guidelines to improve them. Yeah.
All right, we have a message in the chat from Dr. Jane asking if you're aware of ongoing VA efforts to align sedation practices.
Well, I mean, I think that might be a better question for Dr. Atkin, better than me, who's I'm certainly more in the know. Other than our own project, I'm sure that someone else is looking at it.
And that's, I mean, so yeah, so that's exactly what the sort of intent is for Ian's work, is so that we can kind of get back to using guideline-based sedation across the VAs. And we have buy-in from our pharmacists and our network for ICU pharmacists to do this. That's going to, really help everybody come to the table at the different facilities to realize that it's something that we need to do. So it's a path we can map out now that we have the data to show it, but just also needed to kind of convince our stakeholders across the country that that's something worth doing. So another question from Carolyn.
So 2 questions. First of all, great presentation. Thank you, Ian. And thank you, Kathleen, for being a great mentor for this work. First of all is the studies comparing COVID to non-COVID. I'm sure there was a huge impact of not going in and out of the room as part of that, right? They didn't want the patient to move as much and potentially dislodge the ventilator or something else. The second question I have is, I am convinced my phone knows what I'm thinking. So are we going to get to the point where we will know our patient's toe is itching and not increase the propofol?
I mean, I think it's certainly interesting. I completely agree that barrier to care of, PPE and just, if you have 4 COVID patients and all of them are max vented and you're just trying to survive, you're certainly not going to be thinking critically about whether you can even consider weaning sedation. I think, and it's something that, for me, it's just that therapeutic creep. Like, do we just want to try not to fall into that trap despite how stressful it is? And the question of, I think AI is integrating everywhere. I think I saw some commercials that Bing is now just essentially a predictive model that looks like ChatGPT, that they're commercials on TV. So I expect it to be integrated, at least at the nudging use stage to, hey, we've looked at this data and we recommend this clinical decision stage probably within a few years.
Right. I have another question back here. No problem.
Hi, I'm just kind of a follow-up on the age question. Did either your study or the MGH study stratify by other things such as race or gender?
We have not done that stratification yet, but our hope is absolutely to do that. So we have our demographics, but it's an excellent question and one that we're going to really look at closely. So yeah.
Kind of a follow-up to that. You said, humans train AI.
Yeah.
So in that sense, kind of AI can amplify implicit biases that so people train AI, which means that AI can either amplify implicit biases that physicians and everybody already have, or do you see a future where AI can be used to counteract those implicit biases, and how?
Yeah, I think it's a wonderful question. yeah, it feels like there's possibilities with AI, and obviously, you know, the bias that you raise, the concern for bias that you raise. But I wonder if you can, you know, like I think about like the implicit association task that I think people do to sort of develop and learn about their own unconscious bias. You know, I wonder if you can have an AI model that can do that. And I think there are opportunities for AI again to do these helpful. I like it in this, like I like likening it to nudging. I think that AI has an ability to potentially nudge us to make a decision or to consider something when we're caring for a patient that might help us to consider our own biases. So I think that certainly is possible. Yeah.
All right. Thanks everybody for a great discussion. And thanks, Ian. Congratulations on your pulmonary grand rounds.
Bye.